right now, your heart is beating completely normally because 98% of your body's potassium is locked tightly inside your cells.
Right.
But if just a tiny fraction of that potassium spills out into your bloodstream, your next heartbeat could literally stretch out into this deadly sine wave and just stop entirely.
It's terrifying when you think about it.
It really is.
Yeah.
Welcome to another high-yield clinical deep dive. Today, we are tailoring our focus specifically for physician assistant students who are preparing for the Pansingi or the Panera. So if you have boards coming up, pull up a chair.
Yeah, we're getting intensely practical today. We're stepping right onto the wards, so to speak. And to make this really stick, I'll be taking on the role of the seasoned clinical educator, and, well, you will be the PA student on rotation.
Sounds good.
And you, the listener, you are right there with us in the study group. We're going to focus on clinical reasoning and pattern recognition today.
Right.
Because we want to walk through how a clinician actually thinks, not just, what they memorize from a textbook.
I am heavily caffeinated and ready for rounds. So before we walk into our first patient's room, what's our actual mission for this deep dive?
So we have 3 clear learning objectives that you need to master by the end of this session.
Okay, lay 'em on me.
First, we're going to identify the key etiologies of hyperkalemia and recognize the classic fake-out board trap of pseudohyperkalemia.
Oh, the fake out. Love that one.
Right. Second, we need to understand the chronological progression of ECG changes, and more importantly, understand exactly why they happen. And third, master the 3-step treatment framework, which is stabilize, redistribute, and eliminate.
Stabilize, redistribute, eliminate. Got it. So to ground all of this, let me set the scene with our anchor case.
Let's hear it.
Okay, you're working in urgent care. The medical assistant hands you the chart for room 3. We've got a 65-year-old patient with end-stage renal disease, ESRD.
Okay, first big clue.
Right. And the patient sheepishly admits that they missed their last hemodialysis session. They're complaining of this heavy, progressive, ascending muscle weakness. Like it started in their legs, and now they can barely stand up.
Oh, wow.
And on top of that, they say they feel like their heart is fluttering.
Okay, so that is a classic high-stakes presentation. Missed dialysis, ascending weakness, and palpitations. Literally every alarm bell in your head should be screaming hyperkalemia right now.
Definitely.
But before we just, run in and throw medications at this patient, we have to build our clinical reasoning. Let's look at the underlying mechanics first. You just mentioned in the intro that 98% of the body's potassium is strictly intracellular.
Right.
It's heavily guarded inside the cell by the sodium-potassium ATPase pump. Only a tiny 2% fraction lives out in the extracellular fluid and the bloodstream.
So the body is keeping this very tight, deliberate imbalance at all times.
Exactly.
Which means when we draw blood, since we are, only sampling that extracellular fluid, a high potassium level means something has gone terribly, terribly wrong with that balance.
Yes.
Like either the body can't get rid of the excess or the cells are suddenly just dumping all their reserves.
That's the perfect way to categorize it. So let's look at the can't get rid of it category first, because decreased renal excretion is by far the most common high-yield etiology.
Which perfectly explains our anchor case, right? The kidneys are the main exit route, so if they fail, the potassium just backs up into the blood.
Precisely.
Yeah.
But let me ask you this. What if a patient has completely normal kidneys? Where else does this happen?
Well, that's where we get into the medication traps, I think.
Yes, exactly.
Because a lot of drugs interfere with the kidney's ability to excrete potassium, specifically by messing with aldosterone. If I remember my physiology right, aldosterone is the hormone that basically tells the kidneys, hey, hold on to sodium, but dump the potassium.
Spot on. So what happens if we block it?
Well, if a patient is on an ACE inhibitor, like, say, lisinopril, or an ARB, like losartan, we are blocking that exact pathway.
Precisely. You block the pathway, aldosterone drops, and the potassium just builds up. And obviously, potassium-sparing diuretics like spironolactone do this intentionally. But what about over-the-counter medications? Did you catch that in the reading?
Oh, yeah. NSAIDs are a big one. I mean, it's crazy to think that someone just taking a bunch of ibuprofen for a bad knee could literally be putting their potassium levels at risk.
It really is. It alters prostaglandin synthesis, which down the line reduces renin and aldosterone. And here are 2 bonus knowledge medication traps they absolutely love to test on the pansies.
Okay, I'm ready.
Trimethoprim, which is part of the really common antibiotic spectrum.
Yeah.
It actually acts like a potassium-sparing diuretic in the distal tubule. And the other one is heparin, which can actively suppress aldosterone production.
Wait, heparin causes hyperkalemia?
It can, yeah.
That is definitely going in my notes.
Okay.
So that covers decreased excretion. The other major category is when the body's cells basically burst open and just dump that huge 98% intracellular reserve into the blood. So tissue destruction.
Yes. Think about massive trauma. Rhabdomyolysis from a severe crush injury, or a patient who was, found down for 12 hours.
Right.
Severe burns, or even tumor lysis syndrome after initiating chemotherapy for leukemia. Massive cell death equals a massive potassium surge.
Okay, so let's bring this back to the clinic. I'm looking at our ESRD patient. I draw a basic metabolic panel, and the lab calls me 30 minutes later with a critical value.
Let's hear it.
The potassium is 6.5. My immediate instinct is to sprint into the room with a crash cart.
Hold on. Before you treat a number, you have to think about the blood draw itself. I'm going to challenge you with a classic board-style scenario right here.
Oh, boy. Okay, let's do it.
A patient comes in for a routine physical. They feel totally fine. But their potassium comes back at 6.5. You run an ECG, and it's perfectly normal. What fake condition must you rule out? How did the patient accidentally cause it?
Okay, so the mismatch between the lab value and the patient's presentation, that's the big clue here.
Right.
This has to be pseudohyperkalemia.
The fake out.
It's totally a fake out. And it usually happens because of mechanical trauma to the red blood cells during the actual blood draw itself, like hemolysis.
Right. Walk me through the mechanism. How does a routine blood draw cause hemolysis?
Well, say the phlebotomist is having, trouble finding a vein, so they leave the tourniquet on way too long, or they tell the patient to tightly clench and pump their fist over and over again.
We see that all the time.
Yeah, and all that mechanical stress and localized muscle contraction literally crushes the red blood cells in that arm. So the cells pop, they dump their potassium into the collection tube, and the machine reads this terrifyingly high potassium level. But it's only high in that little plastic tube. It's not actually high in the patient's systemic circulation.
That is exactly how you rule it out. True hyperkalemia will almost always show some clinical or ECG signs when it's that high. Pseudohyperkalemia is totally asymptomatic with a normal ECG.
Right.
Your absolute next step in management is always to confirm with a repeat blood draw, without the tourniquet and without the fist clenching.
Treat the patient, not the lab machine. I like it.
Exactly.
So let's say we did that for our anchor case. We repeated the lab, and it's a true 6.8. No tourniquet errors. And the patient's ascending muscle weakness is definitely getting worse. Why does high potassium actually cause weakness?
To understand this, we really need to talk about the resting membrane potential. Potassium is an electrically charged ion, right?
Right.
It dictates the electrical baseline of our cells. Normally, the inside of a cell is very negative compared to the outside around negative 90 millivolts. When potassium piles up outside the cell, that concentration gradient shrinks. So the resting membrane potential becomes less negative. It moves closer to zero.
So the electrical floor of the cell is basically being raised. It's getting closer to the threshold where the cell is forced to fire?
Yes. Initially, that makes the cells hyperexcitable. But as the potassium continues to rise, the cell membrane essentially gets stuck in a depolarized positive state.
Ah, I see.
And the sodium channels, which trigger muscle contraction, they need the cell to reset to a negative state before they can fire again. If the cell can't reset, the sodium channels just stay inactivated.
Which means no electrical signal and no muscle contraction at all. That perfectly explains the progressive ascending paralysis in our patient.
Exactly.
So starts in the legs, moves up the trunk, and if we don't intervene, it paralyzes the diaphragm and causes respiratory failure.
It also paralyzes smooth muscle. So you might see a patient presenting with an ileus where their intestines just completely stop moving, leading to severe abdominal distension.
Okay, wait. I have a theoretical question then.
Go for it.
If it's messing with the electrical baseline like that, does it cause seizures? I mean, if the brain's electrical system is hyperexcitable at first, a seizure feels like a logical endpoint.
I'm very, very glad you asked that, because it is a massive board trap.
Really?
Yes. Write this down in bold ink. Hyperkalemia does not cause seizures.
Good to know.
The depolarization block we just talked about, it primarily affects skeletal muscle and cardiac tissue. It does not act as a central nervous system excitant. So if a board question gives you a patient with a high potassium level who is actively seizing, you need to look for a totally different cause.
Like what?
Like severe hyponatremia or a toxic ingestion.
Got it. Okay, so hyperkalemia paralyzes. It doesn't cause seizures. Now let's talk about the heart, because that is where this gets fatal.
It's pattern recognition time. The exams absolutely love testing the chronological progression of hyperkalemia on an ECG.
Oh, yeah, they do.
So walk us through the step-by-step changes as the potassium levels climb higher and higher.
Okay, here we go. The absolute earliest sign on an ECG is tall, peaked T waves. The T wave gets very narrow, pointy, and symmetric.
Correct.
Then, the PR interval gets prolonged, so the signal from the top of the heart to the bottom is slowing down. After that, the P wave starts to flatten out and eventually just disappears entirely.
Good. Keep going.
Then the QRS complex widens. Eventually, that wide QRS merges with the T wave to form a sine wave. And the final terminal step is when it degenerates into PEA, pulseless electrical activity, or straight asystole. The heart just stops.
That is the exact sequence. But let's push beyond just memorizing the list. Why do those specific changes happen?
Well, visually, I always think of the excess potassium like a physical force. It, grabs the top of the T wave and pinches it straight up like pitching a tent.
That's a great visual.
And as the potassium gets higher, it grabs the ends of the whole ECG strip and pulls outward, stretching the PR interval and widening the QRS until it looks like a lazy sine wave.
I like that.
But physiologically, I know the T wave represents repolarization, right? The heart resetting itself. Why does high potassium make it peak?
It comes back to the cell membrane. High extracellular potassium actually increases the permeability of potassium channels in the heart.
Oh, interesting.
It forces the potassium to leave the cardiac cells faster during repolarization. So repolarization happens remarkably quickly, which translates on the ECG to a very steep, peaked T wave.
Oh, that makes total sense. Fast repolarization equals a sharp, tall T wave.
Okay, so what about the widening QRS? Because that's the heart's main contraction, the depolarization.
Right. Do you remember the depolarization block we discussed with the skeletal muscle earlier?
Yeah, where the sodium channels get sluggish.
Exactly. The resting membrane potential is too high, so the sodium channels are sluggish or fully inactivated. Depolarization slows to a crawl. The electrical signal just struggles to get through the ventricular tissue, so the QRS complex stretches out wider and wider until it merges into that fatal sine wave. Man, it's fascinating how one tiny ion can completely hijack the heart's electrical system like that.
It really is.
But let's be careful here, because I read something in the clinical literature recently. I think it was in the Clinical Journal of the American Society of Nephrology. They emphasize that while you absolutely have to memorize that exact progression for exams in real clinical practice, the ECG doesn't always correlate perfectly with the serum potassium level.
That is an excellent real-world parole.
Yeah, I thought so too.
You could have a patient with a potassium of 7.5, and they might only have Pete's T waves. Yeah. Or they might have a relatively normal ECG right up until they suddenly degenerate into ventricular fibrillation.
Wow.
Yeah, the absence of a sine wave doesn't mean you're safe. Any significantly elevated potassium is a true medical emergency.
Okay, so let's save our patient then. They're sitting in room 3, true potassium of 6.8, heavy legs, and an ECG showing tall, peaked T waves with the widening QRS complex.
Yeah.
We need the 3-step management framework.
Step 1, stabilize. We have to protect the myocardium before we do anything else. What is our first-line medication?
Intravenous calcium gluconate. Or calcium chloride, if you happen to have central access.
Right.
And this is a major trap I've actually fallen for on practice tests. Calcium does absolutely nothing to lower the potassium level. The potassium stays exactly the same.
Exactly. It's a huge misconception. So how does it protect the heart if it doesn't lower the potassium?
Okay, let me see if I can use the analogy from earlier. We said hyperkalemia raises the electrical floor of the cell, the resting membrane potential, bringing it dangerously close to the threshold where it fires.
Yes.
Calcium goes in and essentially raises the threshold potential. It raises the ceiling.
Perfect.
So the gap between the floor and the ceiling is restored to normal, stabilizing the cardiac membrane and preventing a fatal arrhythmia while we get other drugs on board.
That is a perfect physiological explanation. It restores the gap. And the onset is incredibly fast, usually within 1 to 3 minutes, and it buys you about 30 to 60 minutes of protection.
That's pretty quick.
It is. But there is a bonus knowledge illness script here. What if the patient has a history of heart failure and they're taking digoxin?
Oh, you have to be really careful there. Hypercalcemia can actually potentiate digoxin toxicity. If they're on digoxin, you want to give the calcium via a very slow infusion, or honestly just look for alternative ways to stabilize.
Exactly. All right, so the heart is stabilized. Step 2, redistribute. We need to force that excess potassium out of the blood and hide it back inside the cells. How do we do that?
The gold standard here is parenteral insulin, usually 10 units of regular insulin given IV. And we give it simultaneously with a massive sugar bolus, like 25 grams of D50 glucose.
So why are we giving an IV insulin push to a non-diabetic patient?
Because insulin doesn't just manage glucose, right? It's like
Right.
the master key for the cellular doors. It aggressively stimulates the sodium-potassium ATPase pump, which grabs potassium from the blood and just shoves it back inside the cell.
All right.
It works fast, within 10 to 30 minutes. But if you just give a healthy person 10 units of IV insulin, you will completely crash their blood sugar and put them in a coma. So we give the IV dextrose simply to prevent iatrogenic hypoglycemia.
Spot on. Are there any other shifters we can use?
High-dose albuterol via a nebulizer works pretty similarly by stimulating beta-2 receptors, which also ramps up the ATPase pump.
Right.
And you can use sodium bicarbonate, though I think that's mostly reserved for patients who have severe metabolic acidosis alongside their hyperkalemia.
That's right. Bicarbonate alone isn't a great primary shifter, unless acidosis is what's driving the potassium out of the cells in the first place.
Makes sense.
Now, I want to push back on this shifting strategy for a moment. We gave insulin. The potassium shifted inside the cells. Is the patient cured?
No, not at all. The bomb is still inside the building. We basically just locked it in a closet.
Exactly.
As soon as the insulin wears off in a few hours, that potassium is going to leak right back out into the bloodstream. Total body potassium is still way too high.
Which brings us to the final definitive step. Step 3. Eliminate. We have to physically remove it from the body. We have 3 exit routes, basically. The kidneys, the gut, or a machine. Let's look at the kidneys first.
Well, if the patient has functional kidneys and makes urine, we can hit them with a loop diuretic like furosemide. We literally force them to pee out the potassium.
Wow.
But our anchor case patient has end-stage renal disease. Their kidneys are shot. Diuretics won't work.
So we move to the gut. We can use gastrointestinal cation exchangers. These are medications the patient swallows that bind to potassium in the intestines and excrete it in the feces.
Right.
Let's build an illness script here, because there is a very dangerous board trap involving these drugs.
I think I know where you're going with this. There are the newer agents like patiromer or Lokelma, which swap potassium for calcium or sodium in the gut. They are relatively safe and effective.
They are?
But the older drug, sodium polystyrene sulfonate, which most people know as categorized, is terrifying. It has a literal black box warning.
It does. Walk us through that warning. Why is categorized dangerous?
It is associated with severe gastrointestinal ischemia and frank bowel necrosis. It essentially pulls fluid and disrupts blood flow in the gut lining.
That's bad news.
Yeah, so because of this, categorized is strictly contraindicated in patients who recently had bowel surgery, patients with an obstruction, or patients with a paralytic ileus.
And remember what we talked about earlier.
Right. Earlier, we established that severe hyperkalemia can actually cause an ileus. So giving categorized to a patient whose gut has already stopped moving is basically a recipe for dead bowel.
Excellent clinical reasoning right there. So for our ESRD patient, diuretics won't work. GI binders are often too slow for a true emergency, and they carry risks. What is our definitive story? Step 3.
The machine. If the kidneys fail, we become the kidneys. We call the nephrologist and get the patient emergent hemodialysis. It will immediately filter the excess potassium straight out of the blood.
Perfect. So let's summarize the resolution for our anchor case. Okay. We recognize the hyperkalemia based on ascending weakness and a missed dialysis session. We confirmed a true lab value of 6.8. The ECG showed peaked T waves and a widening QRS.
Check.
We stabilized the myocardium with IV calcium gluconate, restoring the gap between the resting and threshold potentials. We temporarily redistributed the potassium into the cells with IV insulin and D50. And finally, we permanently eliminated the potassium via hemodialysis.
Case closed. Patient is safe.
But before we sign off, I want to simulate the pressure of the exam room. I'm going to fire 3 rapid-fire, board-style, multiple-choice questions at you and our listener.
Uh-oh.
We will only test what we just covered. Are you ready?
I am absolutely ready. Hit me.
Question 1. A patient presents to the emergency department with a serum potassium of 7.1 milliequivalents per liter. The ECG shows tall, peaked T waves, and a widened QRS interval. What is the absolute first step in pharmacological management?
The absolute first step is step 1, stabilize. The answer is IV calcium gluconate. And remember, it does not lower the potassium level. It just protects the heart from going into a fatal arrhythmia.
Perfect. Question 2. A patient's routine outpatient lab work returns showing a potassium of 6.2. The ECG is completely normal, with no peaked T waves or PR prolongation. The patient is totally asymptomatic. What in the patient's history likely caused this elevated lab value?
Oh, that is the classic fake out. The answer is pseudohyperkalemia. It's an error from the blood draw.
Right, and how did it happen?
The patient was likely clenching their fist repeatedly, or the tourniquet was left on way too long, causing localized red blood cell hemolysis. The cells burst and dumped potassium into the collection tube. You must repeat the lab draw to confirm.
Spot on. Finally, question 3. Which potassium-eliminating medication carries a severe risk of bowel necrosis and should be strictly avoided in patients presenting with an ileus or bowel obstruction?
That would be the older GI cation exchanger, kyaxylate, otherwise known as sodium polystyrene sulfonate. If the gut isn't moving, do not give kyaxylate.
3 for 3. I'd say you were very well prepared for the PNC.
Awesome. This was an incredible review, but before we wrap up completely, I want to leave everyone with a final thought that goes a bit beyond the textbooks.
Okay, I'm intrigued.
We've spent this whole time talking about how incredibly sensitive the body is to excess potassium. It paralyzes muscles, it stops the heart. But from an evolutionary biology standpoint, there's a fascinating reason why our bodies are so terrible at handling a potassium overload.
Oh, this is an interesting angle. Where are you taking this?
So think about the ancestral diet of early humans. As hunter-gatherers, we ate massive amounts of fruits, roots, and vegetation. Our diet was incredibly high in potassium, maybe like 10,000 milligrams a day, but it was remarkably low in sodium.
Oh, I see where this is going.
Right. Our physiology evolved over millions of years to perfectly adapt to that environment. We developed these aggressive mechanisms like the RAAS system to desperately hold onto every single molecule of rare sodium while constantly dumping the abundant potassium through the kidneys.
So we are essentially hardwired to hoard sodium and flush potassium.
Exactly. But today, the modern diet is the exact inverse. We consume massive amounts of sodium and very little potassium, yet our bodies are still operating on that ancient software.
That's a great point.
We are incredibly good at defending against potassium scarcity, but when the kidneys fail, we have absolutely no secondary evolutionary defense mechanism against sudden potassium accumulation. Our bodies literally don't know what to do with it.
Wow.
Which is why just a tiny fraction spilling out of our cells can immediately hijack our heart rhythm. It's basically an ancient physiological blind spot.
That is a phenomenal way to frame it. The body is an absolute masterpiece of adaptation, but it just hasn't caught up to modern pathology yet.
Well, that is all the time we have for today's study session. Thanks for joining us on this clinical deep dive, and best of luck to you on your board exams. We'll catch you on the next one.